Center for Global Social Policy, and this time, Monk School's Asian Institute co-sponsored a seminar event. Today, we have very luckily brilliant Professor Dr. Soonman Kwon with us to talk about healthy aging and long-term care policies in Asia. As we know, almost every country, including Canada, are now really sort of beginning to realize the population aging, and policymakers and other social actors and economic actors are really thinking seriously about how to address these issues. And so having Professor Kwon with us to talk about healthy aging and long-term care policies in Asia would be a really, really useful learning for us. Let me, before we start, let me say something about Professor Kwon's bio sketch. You probably have seen it on the website, but let me say it one more time. Oh, by the way, I should have said, I'm Ito Peng. I'm a professor at the Department of Sociology and at the Monk School of Global Affairs and Public Policy. I'm also the director of the Center for Global Social Policy here at the Sociology Department. So let me now tell you a little bit about Professor Kwon. I should call you Soonman, since we've known each other for the last 30 some odd years. We met each other back in 1998. And so I was only like baby, eh? I mean, she was already a professor, but
we were kindergarten.
we knew each other in kindergarten through World Bank project. Anyway, so Soonman is a professor and the former dean of the School of Public Health at the Seoul National University. He was the chief of the health sector group in the Asian Development Bank, ADB, and is the founding director of the WHO Collaborating Center for Health Systems and Financing for many years. He received the Excellence in Education Award from the Seoul National University in 2020. He served as the president of the Health Economics Association, Society of Health Policy and Management, Association of Schools of Public Health, and Society of Gerontology in Korea. So he's a really, really well-known and important health economist in Korea and globally. He is also an associate editor of the Asian region edition of Health Policy and International Journal of Health Economics and Management. He was the vice chair of the National Committee on Long-Term Care, a tripartite committee for the decision-making on long-term care insurance in Korea. He holds PhD from the Wharton School, University of Pennsylvania, and taught at the University of Southern California School of Public Policy before going back to the Seoul National University in Korea. He has held visiting positions at Harvard, at LSE, of course, at U of T as well, back in 2006, long time ago. Again, I was just a kindergarten kid. And also at the University of Tokyo, University in Beijing, and Bremen University. And so with that, I would like to ask Soonman to give a talk, maybe about 30, 40 minutes, and then we'll break for the question and answer. Okay, thank you.
Thanks a lot. Thank you. It's my great honor, and it's quite good to be, back to the U of T campus. I took a walk around the campus this morning. It was great to see, many famous familiar buildings. So, today this is initially, it's still ongoing research, but we didn't get a lot of information from many low-income countries of Asia. So it's more about some high-income country, long-term care policies in some of the high-income countries. As I said, I'm an economist or health economist by training, but I'm doing a lot of this research, on policy aspects. But it does go down.
Either. Yeah, either that or the light.
Right. So first, I think most of you are familiar with this aging or health aging, but according to WHO, this is a definition of health aging. So developing and maintaining the functional ability and enables well-being in our old age. So functional ability is, as you can see, is quite comprehensive. Okay, comprehensive. But simply speaking, probably you're familiar with the notion of compression of mobility or expansion of mobility. But the compression of mobility means that we get older but healthier. Okay, so and by doing that, we can meet our basic needs, learn, grow, make decisions, and contribute to our society and build the relationship. And what is the long-term care? These days, I'm working a lot on low-income, low-middle-income countries of Asia about these long-term care issues. So like I was in Malaysia a month ago, and I go to Mongolia after I came back to Korea. So, but oftentimes people think many people, especially in the health sector, they think long-term care means the provision of or utilization of healthcare in the long time, but that is not really long-term care. Long-term care is a lot of so-called social care component. Okay, so that is this is the definition of long-term care according to OECD countries. So range of services required by persons, but if we want to, so it is more about like an activity of daily living. Also, another one is instrumental activities of daily living. So, but the tricky point is that this long-term care sometimes it's not easy to draw a clear boundary between healthcare and long-term care. But a bit easier way to see this is that if the care is provided by medical profession, like medical doctors, it's healthcare. Okay, like in Japan and Korea, Germany, when the service is provided by medical doctors, it's almost 100% sure that it is covered by health insurance. Okay, when it's covered by care workers, it's long-term care. Okay? Non-professionals. Okay, so that's why in long-term care, sometimes it can be provided by so-called informal, unpaid caregiver like family members. Okay, because it does not have to be really provided by professionals, but nursing care is sometimes tricky. Okay? Some part of nursing care, like injections, there's health care. But some part of nursing care can be a long-term care component. So basically, it's a boundary between health and social care. That is long-term care. So this is the health aging. UN emphasizes this health aging concept for a long time. These are combating ageism. So like say 10 or 20 years ago in Korea or in Japan, complicated surgery for 80-year-old person, people tend to think, oh, why should we have this complicated surgery for 80-year-old person? But nowadays we can call it ageism. No, why not? Why? Regardless of age, if that person have a need for healthcare, we should provide them. And also creating age-friendly environments like this, urban planning, transportation, like a public transportation design or pedestrian-friendly systems. We should take into account the aging issues in the designs, age-friendly environment, age-friendly cities, and delivering integrated care and health services. So long-term care, social care, and healthcare should be integrated, coordinated. The key philosophy is a person-centeredness. Okay, person-centeredness. Especially for this one, digital technology can play a very important role. So all the person have faced barriers in transportation moving around. So why they should move around to take, to get care? Rather, they should stay at home or stay in the place they're familiar with. And then providers, healthcare providers or care providers, they provide care. They visit through or telecare, whatever. So that kind of person-centeredness is important concept, and in ensuring long-term care and enhancing care quality. Because for a long time, like sustainable development goals, we push it toward the universal health coverage. But in the communicable disease or conventional framework, we can draw a line between what is health and what is illness, right? When you get infected, you get medicines, you get cured, you become healthy. But in the non-communicable disease, the line between health and illness is not very clear. And care is a very important factor to improve the health. So healthcare and care are, well, interrelated. So we can have a vicious circle or virtuous circle. So we needed not only medical care, but also long-term care, especially in an era of population aging. So this is in the case of a health aging, we emphasize so-called life course approach. We are exposed to health risk for the whole life course, or in a sense, our health risk is accumulated for the entire life course. Or that means that you should invest in health promotion, prevention from the early stage of life. Right? Basically, it means probably you heard about the pregnancy. The health of mom affects or determines the health of the child, but also there are a lot of research shows that the health of the first 1,000 days, like until 2 or 3 years, determines the health of the middle age, but health of the middle age affects the health of the old age. So whole life course should be interconnected. So that means we should invest in promotion and prevention from the very early stage of life, early intervention, health promotion, risk reduction. That means suppose you smoke, like especially young people. You drink smoke until 40 years. It's not too late, but it is much better if you don't smoke, don't drink from the early stage of your life. And absence of this structured long-term care system results in many inefficiencies in inequities. And also when we think about this life course approach, we definitely understand that social determinants of health are so important. You are from the sociology department. So healthcare accounts for a very small component of our health. Of course, genetics is a very important factor. Some research shows that more than half of our health is determined by genetics. So let's take it as given, okay? But for another 50% or so more, there are so many component determinants that affect our health. Like medical care is definitely important, but lifestyle and so many other determinants, and even class or job or hierarchy, they are all important. So we should pay attention to this whole social determinants of health or exposure to health risk for the lifetime. So in that sense, as I mentioned earlier, because of this non-communicable disease or aging, we need a good integrated care and continuum of care. Okay, we have talked about this primary healthcare for a long time, even starting from the alma mater. So, but it's not just primary healthcare, secondary, tertiary, curative care, post-acute care, rehabilitative care, and then long-term care, even institutionalized care or home-based care, and social welfare services. All those should be well interconnected, because as I just mentioned, it's not easy to draw a simple line between what is health, what is illness. They are interconnected. So all these, that's why kind of multi-sectoral governance, multi-sectoral approach is even more important. So these days, I push really hard about this UHCC. UHCC is not enough. Universal healthcare is not enough. This is more like based on the conventional, traditional approach. Now, in an era of population aging, I propose that I support the idea of universal health and care coverage. It's not just health, but the long-term care, social care is very important component that all people need. And this social care, long-term care affects health, and health affects the long-term care. So this is the aging and health concept in WHO, depending on the different stages, when they have a high and stable capacity, declining capacity, or significant loss of capacity, the relative importance between curative healthcare and long-term care is different. So as we approach toward the end stage of our life, then the need for long-term care is increasing. So then, why long-term care system is so important? As we all know, population aging. All high-income countries already experience this population aging, but many middle-income countries are rapidly experiencing this rapid age of population. But depending on, it's not just age, because even for the same age, health functional capacity can be different. And another important perspective is the financial capacity. Many old people in middle-income countries or even high-income countries, they have a limited capacity to pay. So like whether a country has a good pension system or it has a social pension for those poor people, it's also very important. And the family structure, living alone, is a very important concept. Like when I say this, we should prepare for long-term care, immediate response from like countries like Malaysia, Thailand, Indonesia in Asia is that, well, we have a very good family value system such that we feel obliged to provide care for our parents. But that is not true, I think, because that type of value system, family value or attitude toward caregiving is rapidly changing. It's rapidly eroding. I observed this. I just become 61. So I observed this whole thing, even my generation in Korea, I was willing to pay for something for the care of my parents. I cannot. My wife is working, but even if the lady is not working, they are not willing to pay. They're not willing to provide care. Although they may be willing to pay. Probably my son's generation, they don't feel the need to pay for the parents. So the value system is rapidly changing. And also, it's not just the value, but it's the care. When family members provide care for their adults, are they happy? The care recipient and caregiver, are they happy? I don't think so. Because, if many older people think that, I don't want to be a burden to my adult child, but if they have the capacity to pay, many of them think, okay, I'd rather get care from caregivers and pay. So a lot of quality of care issues and well-being issues. So we should not underestimate this. This is hidden cost. In most cases, this is hidden cost. So we should pay attention to this hidden cost, not only to the caregiver, but also to the care receiver. But of course, it can have a negative impact on the labor participation of the informal caregivers, because they should work for those informal caregiving, then they cannot join the labor force. And also another very important potential efficiency argument is that if you don't have a good long-term care system, there's increased overutilization of hospitals. So you call bedlocks, bedlock of acute care hospitals or inefficient social admissions in acute care hospitals. So we can have both efficiency argument and equity argument. Of course, equity argument you're all familiar with. When all the people when they cannot get good quality, high quality long-term care, there's huge inequity issues. Then long-term care system, there are many components, but one of the first things we should think about is that the financing, how to finance. For example, in Ottawa Care Summit, there's a lot of discussions about financing social insurance, but it's not simple. It's very complicated issue actually. So you should also, when you think about this insurance concept, you should talk with the public finance economists because it's a huge financial implications. Because it's not just some more money dedicated to this sector, like you introduce insurance and allocate more resources, make more resources of financial resources available to the long-term care sector. Because who pays? Who pays? And how much they are willing to pay? And it's a big social. This kind of social program means who pays. That those who pay and those who benefit are different. So, and there are a lot of politics because this is a redistribution, huge redistribution. Because this long-term, like one of the big difference between healthcare and long-term care is that healthcare, even these young people, they know they need healthcare. Okay. Right next day, you may go to doctor. The long-term care, the probability of young people need long-term care is very minimal, very, very minimal. So that means it's more difficult for us, more difficult to encourage or push the young generation to pay for something for this long term. That's the big challenge. So from a conceptual, I'm an economist by training. So from a conceptual framework, whether this long-term care is an insurable risk or not, it can be quite controversial. Like Japan, Korea, Germany, we already have a healthcare insurance. Insurance concept, insurance is very, we're all familiar with the insurance concept. So it's a relatively or politically, economically not too difficult to add, in a sense, to add a additional benefit package. And then ask the people to pay more. And also we appeal, like in the case of Korea, I wrote many editorials for the newspaper when we introduced this long-term care insurance like 15 years ago. That hey guys, you are paying. Of course, you don't get benefits yourself, but it will benefit your parents. And another trick was, as I mentioned in the care summit, so for the other children, we can persuade them. Okay, you guys are paying for your parents, but how about young generation? Because in the case of Korea, all people, anybody who pay insurance contribution, they should pay long-term care insurance contribution because long-term care insurance contribution is just added, clever. It's an added on this health insurance contribution. So many young people, they don't know. Although they pay, but they didn't know. It's a trick. And at that time, long-term care expenditure is very low. So anyway, so this is who pays, who benefits is very key. So we are talking about public policy, so we should resort to public sources financing like tax budget or insurance. So it's a clear path dependency, such that if you already have a tax budget-based funding for healthcare, like Australia, Denmark, Sweden, they tend to rely also on tax budget on long-term care. The Germany, Japan, Korea, we used to have a national health insurance. So it's not too difficult to expand, in a sense, expand this benefit package with additional insurance concepts. So path dependency. Private insurance, the market for private insurance is still very limited. Pooling of financial resources this is a quite difficult issue, but first, because this is public resources, such that, like for the same benefits, rich people pay more than the poor, like a tax. Basically, national health insurance, mandatory health insurance is another type of tax. From economics perspective, it's an earmark tax. Basically, a tax. It's a mandatory based on income. So again, there should be a social acceptability that I pay. We receive this. We are eligible for same benefits, but rich people pay more than the poor. There should be a consensus. But I think for high-income country, this part is okay because we already have a good tax system. The degree of progressivity can be different. Another important is central versus decentralized system. Again, this even in Germany, Korea, Japan, we are different because in Korea, we have a national health insurance, uniform, one single big pool. Germany, Japan, multiple insurance pools. So same, because long-term care is added on to this existing insurance one. So long-term care insurance in Korea is same, centralized, one single scheme. It's a small country. Germany, Japan, it's a multiple long-term care insurance. So central versus distant. Again, this is a lot of historical path dependency because Germany, Japan is much more decentralized. Overall, even the political system is more decentralized, whereas Korea is more centralized. Another key issue can be because in most countries, even if we call it national insurance or national long-term care healthcare insurance, but contribution alone may not be sustainable. So government puts some subsidy. So what is the best way to pooling government subsidy tax and contribution? Another tough challenge can be the pooling of healthcare and long-term care. Okay, because from a political perspective, it was a bit easier to introduce long-term care as a separate benefit package from healthcare, because healthcare is a lot of social care component, doesn't have to be provided by profession. So that's why most countries tend to have a separate pool. Long-term care is a separate funding pool than the health pool. But then we have challenges. There's coordination failure between healthcare and care. Because this is health pool, this is long-term care pool. How to harmonize between these two pools? There may be some dumping person to the other. So that's some pooling issues. Purchasing, for whom? Because we say this is a long-term care insurance for older people, but what do you mean by old people? Over 65? Or should it target a more severe one? So you can, why not? We can target over 75, over 80, because UHC is really all universal. But in long-term care, we have a lot of targeting approach. We can target based on need. In other words, you have a need assessment and provide coverage for the severely disabled. You can do it. Or age, like a 75, 80. Income level, target the poor. Living alone, because when you don't have alternative family providers, family caregivers, they can be targeted. What to purchase? Like, do we need home-based care only or institutional care? We talk a lot about the community-based health, community-based care, but it does not mean we don't need institutional care. We need both. Ironically, one of the most difficult challenge for us is to persuade the Ministry of Finance. But when you have a policy dialogue with the Ministry of Finance, home-based care is not easy to persuade them. Even for the people, say even healthcare, we know primary care is so important. Then does it mean that then we have a health funding, health insurance, whatever health funding, and this health fund only covers the primary care, common colds, diabetes, not cover cancer? Is it acceptable? Not acceptable politically. Same. Community-based care is very important, but it is politically or economically more convincing to cover very disabled old people who are based in institutions. Maybe they are higher needs. So a lot of political issues there. For whom to purchase, like we can pay providers based on per service per hour per visit, quality of care. Governance is another big challenge, especially in Asia. In Canada, it's a health and social ministry is a separate.
Depending on province.
Yes. Because in Asia, kind of exception is Japan and Korea. We have a Ministry of Health, Labor. Korea is health and welfare. Japan even health, labor and welfare. But almost all other countries have a separate Ministry of Health, Ministry of Social Protection. But as I said, long-term care falls in the boundary between health sector and care sector, welfare sector. The huge governance issue, I think. Okay. So this is one of the big challenges in the case of Asia. Gatekeeping. One of the big difference between healthcare financing and long-term care financing is that in healthcare, if you feel sick, you go to the doctor or you take the emergency ambulance to the hospital. But in long-term care, you should first go through a needs assessment because we don't have emergency cases in long-term care. So you apply for insurance agency or for the government, and they send the assessment team, and they assess your functional disability, in other words, need for long-term care. Because in other words, even if you say, oh, I need long-term care, that does not mean you get covered. You go through this needs assessment. It checks both physical and cognitive functions. And this is a key eligibility because if the insurance system faces a severe fiscal challenges, then they can tighten this needs assessment system. This is a very important gatekeeping system. This is one of the key characteristics of long-term care that is differentiated from healthcare system. And like Japan, like Korea, and we learn a lot from Japan. So Japan has a very sophisticated needs assessment system. In Korea, we follow the same case, and then we are kind of constantly revising the needs assessment system. But this is another area for like consumers. Some people are not satisfied because, of course, when they are not, if they cannot accept the result of needs assessment, but they can appeal. But also, needs assessment is a kind of a bit systematic assessment plus final approval by the committee. But in reality, in a regional committee, if there's a need appealed by the old person, they tend to approve, right? So, and this is needs assessment in the case of I compare 2009 and 2019, Japan, Korea, Netherlands, Germany. So Japan, a little bit increase. Korea, we started from a very low and huge increase, but still only 9.6% of those over 65 are covered. Netherlands is very unique, right? Even decreased. The population coverage is decreased to 12% in 10 years. Germany increased up to 18%. But there's one trick. That is, in Netherlands, although it looks like that the smaller proportion of old people are covered, but that does not mean that many old people are excluded because, long-term care insurance, in terms of institutional characteristics, again, long-term care insurance system falls, in the halfway between healthcare and pure social care. So in the case of Netherlands, they moved a very disabled population to health insurance. And also they allocated very low severity, like ancillary care or instrumental, ADL issues, those people to social services. So in a sense, the coverage of long-term care insurance looks smaller, but because some population when moved to health insurance, some coverage moved to the local government insurance. And another key characteristics is that in terms of depth of coverage, Japan tends to provide a more generous benefit packages than Germany. So although in terms of population coverage, Germany looks a bit higher, but in terms of the real service coverage, benefits coverage, Japan's system is more generous. So these are some other key issues, issue by issue. So governance issues, we all know governance is the key. So as I mentioned earlier, Japan, Korea is a single ministry, but also the difference between Japan and Korea is also related to those characteristics of health insurance, because health insurance in Korea is a single payer. So in both countries, National Health Insurance Service in Korea, insurance agency for health also has a insurance coverage for long-term care. So in other words, one agency has two programs, separate fund. Same municipalities in Japan, municipality is an insurer for the self-employed. For industrial workers, it's separate pools. But for the self-employed, it's covered by local government. So in a sense, in terms of governance, this insurance system for self-employed is closely tied up with the political responsibility in the case of Japan. And then these municipalities also administers the long-term care insurance. So this is a single pool, multiple pool issue. China, they have a National Health Security Administration. So China has been working with many pilots. So I think it's almost ready to implement the nationwide programs. Because China already has a almost universal population coverage of health insurance system. So they are almost ready to implement, I mean, not the self-employed, but for industrial workers, Chinese government is almost ready to implement. And this National Health Security Administration is an agency covering healthcare system financing. Previously, there's some governance dispute between Ministry of Health, they call it Family Commission, I mean, Health Commission, but basically Ministry of Finance and Ministry of Health and Ministry of Labor and Social Welfare. And then they, to avoid these governance issues, they create this national single agency, National Health Security Administration for health insurance. And now this agency will also work on this long-term care insurance. Thailand, as you know, is a very famous universal coverage of healthcare, a universal coverage scheme, but they are not ready. They are not yet have some nationwide system funding for long-term care, but they are piloting various ones. One very important pilot is that this National Health Security Office is a kind of funding agency for healthcare, and they allocated not big amount, but small amount to each local government. And then local government, they have their own kind of a decision to combine this healthcare allocation from NHS. So, but they combine it with their own local government social welfare services and provide care for, I mean, they meet the need of long-term care of all the people in their own locality, but it's a very early stage. Other countries not yet fully implemented. So again, this is a centralized versus decentralized governance is a big issue. Like Australia, South Korea is one in healthcare and long-term care, one centralized system, whereas Japan and New Zealand is a decentralized system. So, but even in the decentralized system, like a major key policymaking for planning, financing, regulation is done by central government, like Japan, although it is multiple insurance, basically by municipalities, but they have a uniform standard for benefit packages, both in health insurance and long-term care insurance. And also even in New Zealand, they have a good commissioning, a lot of policies for commissioning. So provide harmonization in among those local government issues. So still, but optimum degree of decentralization is a lot of contextual and issue, but it depends on the political culture. Because it's not just a health and long-term care issues. It's deeply rooted in their own culture of political decentralization. So let's move. Financing, these are the expenditures of long-term care. I'm saying like in Japan, long-term care expenditure accounts for about 2% of GDP, much lower in Korea. So again, there are also big difference between Japan and Korea in terms of population coverage, although we call it health insurance system. In Japan, there are two types of beneficiaries. One type over 65 and the other type from 40 to 64. So two types of beneficiaries. And the beneficiaries of 40 to 64 years old, they are eligible. Their eligibility is much more restricted. Okay. So in a sense, these 40 to 64-year-old, they pay contribution, but they know the probability that they will be eligible for benefit is much more limited. It's clever, okay? Because I mean, they want those 40 to 64 who are in the working age, they want them to pay. Okay? So they should give some possibility for them to get benefits, but not very generous, but some possibility. So, but that means that those below 40, they don't pay, they are not eligible. I think I joke to my Japanese colleagues, you are very honest in a sense, because those below 40, wow, the probability that they need long-term care is very low. But Korea, we saw this. Okay, why not go a bit further? So in the case of Korea, everybody. But we have two types of beneficiary. So over 65 is ordinary, and those under 65. Those under 65, they pay contribution, but they know their eligibility is much more limited. So out of the total beneficiaries of long-term care insurance in case of Korea, more than about 90 to 95% are those old people. And there are some like a small segment, proportion of younger generation, they get some benefits. In case, for example, even the young people, they can get a Parkinson's disease, and then they need long-term care. In that case, they get covered. But ordinary types, other types of like a disability, long-term care need, for all the younger people, they're not covered. So this is the case. So even in the same insurance system, Japan and Korea is different, like different population coverage pooling. Both in Japan and Korea, national health insurance and long-term care insurance have separate pools, but we face some challenges in the coordination because they are separate pools. So in a sense, this separation is more like a strategic or political decision, because we do not want the medical doctors have predominant power in long-term care insurance. Okay? Because we are worried that when long-term care is included as a part of big healthcare system, then medical doctors, like geriatric medical doctors, may be over dominant of the system. It can be costly. So we make a separation. So same case like Germany, Japan, Korea, we all have a separate health pool and long-term care pool, but we face the challenges of the coordination between these two pools. And Korea the challenge is even more severe than the other countries, because in terms of the role of private providers, Korea is the worst. Okay, I mean, even in Japan and Germany, private providers are quite prevalent, but in the case of Korea, the real majority of providers in Korea are private. So in the private sector dominated system, coordination is quite difficult, because in the private sector dominated system, patient means money, right? They do not want to refer their own patient to other providers, to other sectors. Probably you've heard about the huge physician strikes over more than 1 year against the increased number of doctors. Probably it's not, you cannot imagine it in the case of Canada, because in Canada, the physician provider income is more or less, predictable and capped. So more doctors means a reduced workload. But in Korea, it's a private. We have a health insurance system covering everybody, but provider themselves are all private. So more doctors means more competition, reduced income. So that's why nationwide strikes. So this is even for the insurance system, a different funding mix. Like Japan, as you can see, the government funding accounts for the half of the public funding. It's quite extensive role of the government. And Korea government role is much less, so 20% government funding and premium contribution and some co-payment. Netherlands, government subsidy only in exceptional cases, but Germany, no government subsidy. But Germany is also a very interesting case. Like in terms of premium, contribution. I raised this, I quoted this German case and asked the Korean government that we should follow the German example. That is, in Germany, the contribution for long-term care insurance depends on the number of children.
Oh.
If you have a smaller number of children, or even if you have no children, you should pay high contribution. But is it reasonable? So you're like, isn't it reasonable? Because it's But in the case of Korea, it's not yet time to discuss. But in Germany, yes. So it depends. There's a discount of premium if you have more children. I think it's reasonable, because it's kind of almost like a pay-as-you-go insurance system. Purchasing, most countries have in-kind benefits, but as in the case of Germany, they have cash benefits, but in Japan, no cash benefits. In Korea, cash benefits only in very exceptional cases. And pricing of services, price can be set by the government, or set by through the regional negotiation, different. And co-payments, again, in the case of healthcare, copayment is minimal. I mean, we think so, but long-term care is a bit different because long-term care, I mean, in the case of healthcare, like when the young people have a huge healthcare expenditure, they have a limited way to spread the risk. They cannot sell their asset when they're young. But in the case of old population, they can have a reverse mortgage, blah, blah, blah. So in most countries, in the long-term care system in high-income countries, copayment is adjusted based on their capacity to pay. Almost all countries, which is not the case in healthcare. But in long-term care, it is like a copayment relies on your income. So if you only have a higher income, you pay higher payment. So these are the types of long-term care service, usually home-based versus residential care. And then there's activities of daily living, central government, health, aging, social services. So I think this case of Australia is a very important, very unique case and quite a lot of lessons. This is tax-based system. This is not insurance, but there are three types of major packages in a sense. Residential care, and comprehensive home care. And another very important case is early level care and support. I think the first one is rather unique compared to other countries. You know, it says early kind of interventions, a bit similar to capitation in healthcare. So in other words, for those who have a very minor level of disability, they are registered, they choose their providers in the community. And the block grant to the providers, such the providers are with this block grant per person, per enrollee registered, they have the responsibility to provide care when they're needed. So it's a bit early stage. I said this is a bit like a capitation payment in the case of healthcare. And comprehensive home care, still home care. So in this case, annual funding is given to recipient. And they choose what type of services they purchase. They select providers. But for those who I mean, either because they live alone or because they have very severe disability, those who should stay in residential care. In that cases, the payment is given to providers like hospital, payment to hospitals. So the three types of things. And basically, so eligibility of the public funding is based on need, okay? Eligibility doesn't take into account the income level or asset level. So only based on need, but there's a user fee. There's a user fee, which is based on your income. So in the case of residential care, it is based on means test. It's not just income, but it's an asset test. But in the case of home care, only take into account income test. So eligibility is based on need, but user fee copayment takes into account the ability to pay. And also in terms of service delivery, there are increasing role of private providers and consumer choice. Look at that, like an entry-level care is a block grant to providers, but consumers choose to which provider they will register. And the second, comprehensive home care, providers choose. And this is the case, like a purchasing from providers, private providers are increasing. So that just the public funding creates a purchasing power. So in a sense, this is some difference in healthcare and long-term care. Even in a country where the dominant, which has a dominant public providers in healthcare, they tend to have more and more of a long-term care. Why? I think there is this is important, interesting question. Why there are more private providers in long-term care compared to healthcare? First, probably because the role of consumer choice can be a bit higher in long-term care compared to healthcare. So in other words, information asymmetry may be not that serious in long-term care compared to healthcare, because either the old people themselves or family members can choose. Another way is that, depending on the development of the welfare state, probably healthcare system is developed when the welfare state has huge physical capacity. So they already achieved this huge, big public system. It's not easy to reduce the role of the public. Whereas long-term care is a more recent issue, so the physical capacity of the welfare state is slightly different from previous decades. So they tend to have more private providers, but also quality control mechanism is very important. So this is one of those real roles of insurance system, like a insurance system in Japan, Germany, Korea is a very strong purchasing role. So when the providers submit the claims, there's a very strict review and assessment of the quality of care providers. So that is called the purchasing mechanism. So in healthcare financing and long-term care financing, these days, where the money comes from is important, but at the same time, how to allocate this money to providers. That means you do not just government insurance agency, do not just simply give the allocated money, but this agency, government, purchase services for the benefit of consumers and the citizens. When they purchase, they take care of the quality, a lot of monitoring, okay? Or they just select the provider. They don't purchase services from all providers, but they select, they review, evaluate the quality of services, and then select. So this is so these days there's increasing emphasis on the role of purchasing. Workforce is becoming a serious issue, but again, it's an important part of this purchasing. So in the case of Japan and Korea, when they purchase services from providers, one of the very important quality criteria is the placement. How many care workers, the employee, and so workforce is important issue. So in those two countries, very formal curriculum and certification system, but still high turnover because it's not an easy job. And young people do not want to work in this sector. So this is a very serious issue. So in the region, import of care workers is a hot topic, very politically sensitive. I worked as a vice chair of the National Committee for Long-Term Care Insurance in Korea. In that case, there's a big, whenever government wants to talk about this potential import of care workers, there's huge opposition by labor union. Yeah, because labor union think that if there's a import of care workers, it's a decreasing bargaining power of the labor pools. And also how to support family caregivers is important, increasing service delivery system. So as I said, need assessment is the key. So depending on the design of the need assessment, we can target the poor, we can target the most severe people, we can target those who don't have family support. And the goal is the balance between institutional care and home-based community care. Unfortunately, it's easy to say, but very difficult to do, especially when they are a very important role of private providers. Because again, the private providers, they still think that the patient writes down money. So integrated care, person-centered, this is a dilemma. We are struggling. We are really struggling. Japan is better than Korea in that sense, but still, this is a private sector dominated system, and people are used to choose free choice. So that's it. This is a never-ending kind of a dilemma, I'd say. How to coordinate healthcare, long-term care, social welfare services. In that sense, I think Japanese model is slightly better because Japan municipalities, they are the insurer for the health insurance, right? Self-employed health insurance. They are insurer for long-term care insurance, and they are also provider of or responsible for local level community welfare services. So they are at least at a better position to coordinate healthcare, long-term care, community care, although still many challenges. Whereas in Korea, healthcare and long-term care by National Health Insurance Service, but local government is only takes care of this local level community welfare service. This is a really big challenge. So this is fragmentation is an issue. So the way forward. So many, I didn't show the statistics, but unfortunately, many Asian countries are experiencing expansion of mobility rather than compression of mobility. So they tend to live longer, but not healthier. So that means that people's demand for need for long-term care will definitely increase. So that's what I'm saying. Compressed speed of aging. So aging speed is in Asian countries much higher than that in European countries, but expansion of mobility. And informal caregiving is less sustainable. I keep saying this in many low and middle income countries of Asia. Please, you cannot rely on elderly care by family. It's the same case of a child care. This is the key example I always show. Long time ago, child care is at the hands of family. Even myself, sorry, I didn't attend the kindergarten. Primary school is my first formal education. But right after my generation, all children go to kindergarten. So that's the socialization of childcare. Same. We cannot rely on family, old people's care by family members. It's time to seriously think about socialization of childcare. So dual imperative. So we should go toward the virtuous circle. If you have a good healthcare system, it can reduce the need for long-term care. But at the same time, if you have a good long-term care system, it can reduce the need for healthcare. This is the virtuous circle. For example, falls. As we know, falls is one of the major, significant, most serious risk factor for health of old people. If you have a good long-term care system, we can definitely prevent those the falls. So there are increasing number of articles showing that the positive for me virtuous circle between healthcare system and long-term care system. I think this is the final one. Common challenges, blah blah blah. So vision, aging in place. Aging in place, that's intermediate, but it's not the final goal. Final goal is that all the people live happily, healthy. But in that sense, for that goal, aging in place is the intermediate goal. But still, it's not, as I said, it's a means. It's not the goals, because some people, they do not want to stay home. Possibly. So they may want to stay in institutions. So our goal is that all the people choose where to stay based on their need, based on their preference, without financial barrier. So let them choose. That's the good system. We should not push them home. We should not push them to institutions, but they can choose without financial barrier. Some old people, they want to stay. They want to get care by children, or some children can be very exceptionally nice to provide good care. In that case, let them do that. But they were not forced. Older people should not be forced to do that. And the young people should not be forced to provide care. That's this ideal system is more this preference, need and financial assessment. So healthy aging, delay the decline in health capacity, or prevention, and we should go for this aging in place. I think that is it. So if you're interested, some papers on. Thank you. I speak too much. Sorry.
Well, thank you very much, Soonman, for your really stimulating and actually really informative presentation. Now, I would like to break open for Q&A on this. Please feel free, both for people who are here in person and people who are online. Please raise your hand if you have any questions, comments, thoughts.
From Sergi.
Oh, so Sergi has a question. Could we, Marie, Professor Flora, please.
Well, thank you, Professor Kwon, for such an very interesting and very comprehensive presentation on long-term care. Your presentation raised a few sort of, well, first of all, some comments, but also some questions. So one question I have, I'll just probably mention two or three because I don't want to take too much time, is that, in terms of, let's say, persuading government, in particular the Ministry of Finance, there are two aspects to it. One is that, why could you not, in terms of, for example, financing LTC, why is it difficult to persuade people or society in general to pay for LTC. Okay, and you mentioned the fact that the difference between healthcare and LTC. But one can also think that LTC is like pension and social security. You're saving for old age, which is social security and pension. That's acceptable by society in general. But in particular for LTC, it's saving for healthcare needs in old age. Because everyone, if they are lucky, will grow old. The one thing, however, is the uncertainty and when you will exactly need the health care in your old age and the extent to which. So the question, so in other words, there could also be an argument, economic argument, as to why everyone should contribute to LTC. If that's, you know, a way by which you could finance it, whether by contribution or by taxation. My thinking is, and this is my own opinion, is that the difference between healthcare and long-term care is that healthcare, as you mentioned very clearly, is done by professionals. Whereas long-term care can be done by unprofessional, including family members, caregivers who may not know anything about caring for the elderly. So there is an implicit assumption here that we can let go of the long-term care because there's an abundant supply of family members who are willing to do it, or extended kin, or friends, or someone. Even though, as you pointed out, the reality is that's no longer a good assumption to make. But my thinking is that that thinking can still be prevalent among policymakers, not necessarily in society, that, hey, just like with childcare, I live in the United States. There has been no universal childcare bill because there's an assumption that family members, particularly women, are willing to take care of it. So we can just forgo that argument. So that's one point. And the other thing that I also want to raise is that from an efficiency argument, if one has to make this case for the Ministry of Finance, you mentioned the issue of hidden costs of having long-term care being, sort of shouldered, or lack thereof, or being inadequate, being shouldered by default by family members. Well, the hidden cost, as you pointed out, is the impact on the labor force. And I think now increasing number of studies whereby the burden of long-term care, at least in the case of the United States and maybe also in other countries, actually impacts both men and women, but in particular also women, age 50 and over. And so that's one. So you can make so this is the opportunity cost that you have if you don't have long-term care. It's basically you have this decline in labor force participation, which will reduce growth and which will reduce government revenue by way of taxes and so forth. The other hidden cost is, of course, fertility rate. And, there could be some direct relationship between the sandwich generation, i.e. taking care of the elderly, and the decline in fertility rate. And making those arguments visible can also justify the importance of having, even though it's partial, the public provision of long-term care. Anyway, those are just some comments. I'd like to hear your thoughts on that.
Yeah, I agree with you. But so that's the, kind of dilemma I have. And my question, because we all live in at least people in this room, we are living in a democratic political system. If people really think this is important policy issue, politicians and government will respond. Agree? So the fact that the politicians and government do not respond to this requested need means that either first, the demand and request is only among those among us who are expert in long-term care, not in from the general population large enough, or your democratic political system is not working well. It's a dilemma. So, and also, I mean, as I know, I'm fully hearted supporting this long-term care system and financing. But if I can be a devil's advocate, for example, when I talk with these issues for public finance economists, they can say, I mean, good question that Maria mentioned, that these family caregivers is a huge cost, but they said, well, still, it's available. So some people will be buried. And because government, they have multiple priorities. So the question is, this long-term care need is really high enough for them, for politicians. We think it's high enough, but it seems that they don't think so. That's why they don't accept it. Also, labor participation, because one of my when I debate with the public, I mean another labor economist, a public finance economist, they say, okay, if suppose that the potential informal caregiver, they have a very high income, but then they are willing to, they will not sacrifice their labor. Instead, they will hire, they have a capacity to pay, they will hire the care workers for themselves. And then, but low paid, like caregivers, they are willing to, because comparing the labor, I mean, wage sacrifice versus the cost of hiring care workers, they may willing to, okay, rather than hiring care workers, I'd rather be paying. So I'm not sure, of course, wage does not necessarily mean the productivity or value added to the society, but if there's some linkage, then the economists may think, or government may think that, if the value of labor of this caregiver is not high enough, then they may choose to stay home and provide care. So there are a whole lot of many different counter arguments. So we should have more debate, deliberation, and sharpen our logic. And we need some kind of advocacy, so society level advocacy. Otherwise, don't estimate. We can easily persuade the politician. No, it's not. Yes, sir.
Yeah, go ahead.
Professor Kwon, thank you very much. I mean, the quality of these questions, I think, demonstrate the quality of your presentation. Just kind of a question in terms, if I understood your point correctly, in terms of, in a democracy, kind of what the people want in influencing governments, at least in Canada, and I think a lot of the Western countries, my view would be, and I think in East Asia, you're better. I think in many ways, our democratic processes have been hijacked by big business. And the politicians, like who gets them into power is in many cases, the common person, fine, we pay lip service to that. But the big money in terms of advertising and all that type of thing, driven by business. For example, in Canada, in terms of long-term care, 40 years ago, we were, I'm going to use rough numbers and not exact, but they're close. We were 2/3 publicly delivered. Now it's the opposite, 2/3 private, basically. In COVID, our death rate in private facilities was 4 times that in public facilities. And we went from a huge waiting list in terms of long-term care institution. We love to institutionalize our elderly in Canada. We need to kind of get with the program, but we're not there. And I think we're a long way from there. But we went from a huge waiting list to 14,000 empty beds in Ontario, for example. Why? People wouldn't put their loved one into a long-term care facility during COVID because it was basically a sentence of death. What did our government do? Paid those beds, paid the companies those beds as if they were full. Absolutely zero accountability. So the point I'm kind of making is, and in Canada, there's a history, if you will. We had wanted universal healthcare since 1919. We got it in 1968. You know, what the public wants is kind of not driving the ship. So I guess I'll leave it at that. I want other people to have a chance, but if not, I got a question for you.
Yeah, Jim and then Jindy, okay.
Yeah, thank you very much for the lecture. I've read your stuff before and it's great to see you. And I frankly, couldn't really disagree with anything you said because it's so sensible and the political advocacy issue is so important. I'm a director of a program, a Master of Health Administration with a focus on community care specifically. And, you know, anyone I mention the idea about universal long-term care insurance, but many people don't know about that idea. No one has said that's a dumb idea. It's a no-brainer in many respects, and that it doesn't seem to happen is just I just don't know how it works. Is part of the issue is a big issue as you're saying it's easier to tack it onto a social security system? Is that one fundamental thing? And in the Canadian system, I think because our universal healthcare system didn't include pharmacare or dental care, that I think that's the heavy lift we probably want to do here. This is the Canadian circumstance. So I guess my point is, what's the best way to get this done from all your experience?
Yeah, it's an interesting dilemma because all high-income countries, I mean, depending on their trajectory, those who have a national insurance system, they have a long-term care insurance, like Germany, Japan, Korea. Those countries which relied on this tax funding for healthcare, they also expand those programs to the tax funding for long-term care. In a sense, I think Canada is a bit of kind of a outlier that the government does not, because you have a UHC, I mean, tax-based basically UHC for good system, but why not government willing to? Why? What is a major reason the government is not willing to expand the tax-based funding for long-term care? I mean,
I wonder if I could just comment on that because so Canada's universal healthcare system is now tax funded, but it was not always tax funded. When it was first introduced back in the 1960s, it was a national social insurance. So for those people who are over 50 now, will remember Ontario used to have OHIP. What is that? Ontario Health Insurance Plan, in which you pay the premium based on payroll tax, just like pension and EI. So, but then it was after the Canada Health Act that was introduced in 1981 that it became sort of much more tax funded. So what I'm trying to say is that this is something that Caroline Tui and I have both kind of tried to push before, that in fact we do have pre-existing template of social insurance model. We still pay social insurance like EI. What is employment insurance? Well, it is social insurance in case you lose your job and it gets deducted from your payroll every month. What is pension? Pension used to be a pension insurance, but dedicated for your retirement. And so in a way, if we're talking about the path dependency, we should kind of refresh our mind to the Canada's social security system and say that we do have that path dependent sort of pattern of social insurance. And so what Caroline Tui and I was trying to say is, what if we tack it onto the EI or sort of put it in, put long-term care insurance within the context of that CPP, QPP, EI kind of insurance? Okay, those are mainly sort of dedicated to current employees, but if we could kind of push it that broadly for people who are not necessarily formal employees, but also small businesses and things like that, that might be possible.
But the case is that, as you mentioned, the EI basically covers those employee sector. So that means that self-employed, like a small business single owner, cannot be covered and make one thing. But the other thing is that one big difference between tax-based funding and insurance-based funding is that tax-based funding is entitlement. We call it entitlement. Whoever, whether you pay tax or not, okay, whether you pay tax or not, Canadian citizen is eligible for this tax-based funding. Whereas insurance means a contributory approach. Insurance means if you pay, you get benefits. If you don't pay, you don't get benefits. Of course, people say, well, let's make it mandatory. My only question is, mandatory really means that we can call it mandatory by law, but it's a huge issue of enforcement. Can you send the person to jail if they decline to pay contribution? No, politically impossible. So that means that if you don't pay contribution, even if mandatory, if you don't pay contribution, they're dropped out of the coverage. Then the question is, like a healthcare, let's think about the risk. Employment, everybody knows, even the young people knows that I can be unemployed. So I think the willingness, there are always some willingness to pay contribution for unemployment insurance. Healthcare, as I mentioned, young people, I can be sick tomorrow. So they always willingness to pay for healthcare is higher than healthcare. Pension, how about that? Retirement is 100%. I mean, if you survive. As long as you survive, retirement risk is 100%. Long-term care is different. You get, even if you retire, I mean, it doesn't have to retire, but even if you become a certain age, you can be healthy and you may not need long-term care. So that's why I say in terms of insurability perspective, although I fully hearted support these funding ideas, but in terms of insurability, in terms of the willingness to pay for contribution, this long-term care insurance, unfortunately, is lower than the others. I think that maybe that's why the clever politicians do not respond.
I think you had did you have a comment or Cindy?
There's also like my thought when I was listening to your lecture, and you said that it's difficult for you to convince other governments to prevent other governments to socialize elder care, whereas in you compare them, whereas we're kind of socializing childcare in many countries now. And I was thinking maybe the difference between socialization of childcare and socialization of elder care is that when we think about socialization of childcare, we like this image of institutional care because institutional care means that children will be better educated and they will have better education and treatment. They will be better workers in the future for the society. And by putting the children in the daycare, parents, especially mothers, can bring something to the society by participating in the workforce. So for the society, there is a real interest to socialize childcare. But on the other hand, I think that for elder care, there isn't real interesting outputs or outcomes that the government can pick up because, first of all, the image of institutionalizing care by putting elderly people in one place is not very acceptable for many society. And also, even if it's their home care, well, there isn't something that's beneficial immediately for the government. It's just like bad money, not bad money, but in a sense that
basically, if you compare this investment in, and unfortunately, as I said, I used to be a researcher on this issue, but now this is my problem because I'm old. Because when we compare the investment in child health, or investment in old people, unfortunately, we can never win the investment in child care. That's true, because child care, if you have a good investment for child, this is a lifetime rate of return. So, in the WHO headquarters, still now, I think there's a unit merge, such there's a life course approach, something that they combine both child care and old people's health in one department. The result is obvious. The more and more focus on this child care, because in terms of efficiency argument, in terms of whatever argument, we cannot win. we cannot win. That the child can.
I wonder if we could just stick on this topic for a minute, because that was something that I think Maria was also pointing at. Sort of the question is, so we do know that, you know, like childcare, investing in childcare is sexier, much more convincing, but with positive impacts. We do know from the macroeconomic side, the benefit, right? Positive impact of investing in long-term care. Things like its impact on the labor force participation for men and women. Things like, you know, so that alleviating that hidden cost of unpaid caregiving and both social and economic, all these costs that we could actually alleviate, and yet we can't seem to still convince the government policymakers about, you know, investing in care. So I just want to turn around and ask, what do you think? How can we narrate? What would be your suggestion of strategies to sort of convince, or you know, what would be the kind of you know, advocacy strategy that you will you could think of?
Actually, first of all, there's no clear answer, because as I said, this Canadian case is bit like a, I mean, unique case for me. Why among the high income countries is one of those the lowest investment in all the people's care, I think, in Canada. I mean, still it's a bit it's a curious case for me. Maybe we need a multiple kind of cocktail approach, such that, you know, we should show some evidence, like because of this care burden, there's a huge inefficiency. Like there's typical cases, as I said, social admissions in hospital. Many, you know, if you don't have a long-term care system, people do not want to leave the hospital, because if they leave the hospital, there is nowhere to go. So this inefficient social admissions in acute hospital bed luck is one of the very strongest argument for efficiency. And as mentioned, labor force participation is another efficiency argument, but potentially, I think, depending on, you know, wage level of this caregiver can be tricky, but there's one. But also, I think we need some kind of you should mobilize media such that how, I mean, when we don't have a good care system, how, I mean, some narratives, you know, how many people are suffering? How many people are suffering? Although we say they can rely on family caregiver, in reality, family caregiving does not work properly. So I think we should provide this kind of not just you know, economist or efficiency argument, but also this kind of human sufferings. As you know, Canada is advanced, much more mature than your southern counterpart country, then how Canada can stand this? I mean, I think that kind of you should mobilize various resources, and you should persuade first some of those economists, the public finance economists working in the government. I think that otherwise, if it only the big consensus building among those or among us who fully committed to this long-term care aging issue, then we cannot. It does not mean that we can persuade the government. I think so, but sorry, it's not a good answer.
I think those are all very, very good ideas.
And
Okay. Yeah.
Mr. Kwon, when you were talking about long-term care insurance, was I interpreting correctly? Would you keep your two baskets of money, I guess I'm gonna say, separate?
Yeah.
Like, yeah,
Separate. So we have a health insurance contribution. It's very clever. A fixed percentage of the health insurance contribution is a long-term care insurance contribution. That means currently, like say, 10% of health insurance contribution is allocated to the long-term care. So that means even if a long-term care insurance contribution rate like is constant, but we always every year we adjust premium rate. in insurance system. So when health insurance contribution rate is ever increasing, then allocation to long-term care is increasing, but it's separate. So we have a health insurance contribution and long-term care insurance contribution, but long-term care insurance contribution is defined as a fixed percentage of health insurance contribution because we want everybody who are enrolled in health insurance are automatically enrolled, automatically paying long-term care insurance contribution. So it's a separate pool, separate pocket. Although it is administered by the same agency, National Health Insurance Service. It's a government agency managing this funding, but two separate pools, two separate funding.
I haven't given this a lot of thought, but I think that's a really smart idea because the two types of care are very, very different as well. And it seems to me, we in a society would want to look at each pot differently to see how well is that money being spent. Very interesting.
I think so. I mean, that's why in Germany, Japan, and Korea, it's the same, like a same agency, but they administer two separate pools. So funding are separate, but governed by same agency. So Germany, same health insurance, they have a multiple sickness fund, but sickness fund administers both insurance funding and the long-term care, long-term insurance, health insurance funding and long-term care insurance funding.
Yeah, I have a follow-up question on that. I have to confess first, like when I was in South Korea, I didn't know I actually paid.
Yeah, people didn't know.
And thanks for letting me know it. And it brings me like really curious about like how contentious it is nowadays from younger generation regarding the pension politics. But vis-a-vis like what we're seeing in long-term care, like younger generation actually did not notice.
Still not visible.
Yeah, and yeah, there is still a question like because pension as a pay-as-you-go system, like there is like a lot of challenge from the younger generation, the financial sustainability of this system. There are a lot of politics of like pension fund try to like rely on financial market to earn more profit out of their financial investment, like versus national pension in South Korea doing the similar thing. But I'm curious to know like what type of effort is currently going on like in South Korea or other like similar system utilizing this type of long-term care insurance. Do they also like try to rely on financial market to like financially sustainable in the future?
Well, although this health insurance and long-term care insurance is basically short-term insurance, short-term contract. So in all those three countries, we adjust premium every year. So we don't have a huge fund, accumulated fund. So when there is accumulated fund decrease, in other words, when the annual deficit is increasing, then we basically every year we're increasing long-term care insurance. And then in that sense, governance is important. We have a governance structure. It's called National Health Insurance Committee, Long-Term Care Insurance Committee. It's a tripartite committee. So 1/3 of the committee member is coming from payers, like employer association, labor union, because health, this again, another one is an insurance contribution in those countries is shared equally by employer and employee. So employer acceptance is another very important issue. So anyway, so we have this payer group and we have a provider group, like a healthcare providers or long-term care providers. And we have a public participant, like a government ministry and some expert like me. So I serve both National Health Insurance Commission and this long-term care insurance commission. And then every year we make a decision how much to increase insurance contribution. So every year we increase the long-term care insurance contribution rate, health insurance contribution rate every year because expenditure is increasing. So then when the expenditure is increasing, our deficit is, sometimes surplus turns into deficit, then we should increase in contribution. With population aging, as I said, insurance contribution is ever increasing every year without any exception so far. So this is a dilemma. But clever, as I mentioned, because pension is a separate. So young generation is a very clear, understanding what it means. But long-term care insurance, although it's a separate pocket, but administered by one agency, and it's kind of it's regarded as or designed as or regarded as a supplementary additional benefit package of health insurance. So people tend to think that this is one thing, all this is separate. So it's a kind of clever strategy. And when it was first introduced, like almost 20 years ago, long-term care insurance expenditure is very low. The premium rate at that time is very low. It's very negligible. So that's why it was introduced almost 20 years. But many young people at the beginning, they don't know.
In a way, this is a conversation that, I mean, in a way, the Canada Pension Board also does a similar kind of sort of adjustments from time to time, not on a yearly basis, but really based on how much, premium to increase, changes in, the changes in the payout rate and things like that. So I think for every insurance, I think that in most countries that kind of adjustment gets made depending on the demographic structures, labor market, conditions and things like that. I know as Professor Maria Floro, sorry, I keep calling you Suji, has a question. Go ahead.
Yeah, well, this conversation is really interesting, but I'd like to shift from the issue of financing to the issue of provision of the care services themselves. I think your presentation is comprehensive because it also address this very important point. And from what from listening to your presentation, there are primarily two sources of, two types of providers. You have the market and you have the government, right? And, there are many different combinations of the two. But from the viewpoint both of equity as well as efficiency, do you see certain limitations and constraints on just pure, like in the case of South Korea, majority of it are outsourced by private providers? Because in my view, this issue of quality of care, okay, makes it very important. And as you pointed out, the information asymmetry, frail elderly will not be able to complain just as much as young children will not be able to complain, right? If the service is bad. So you also have the issue of regulation and the importance of regulation to maintain the quality and also the working conditions of the decent workers. So do you see any kind of limitations of either the market provides provided type of care versus the government provided type of care? What are your thoughts on this?
Korean case of service delivery, private sector dominated service delivery is a disaster. Of course, disaster. Like not only this long-term care provides, like hospitals, 95% of Korean hospitals are private. Can you believe it? So among OECD countries, the role of the private sector, both in healthcare and long-term care, especially in healthcare, the role of the private sector in Korea is the highest among OECD countries, even higher than the US. So that's why we are, physician strike this year is not only the first one, no, we are plagued by frequent physician strikes. And during the COVID-19, what happened? Private hospitals, they provide all possible excuses that not to accept COVID-19 patients. So there should be, we know that the public system also has many problems as well, but at least there should be healthy potential check and balance and service and a competition. But Korea is one extreme case that the predominance of private sector has so many kind of inefficiency and inequity, because inefficiency means a huge demand inducement. Unnecessary care, huge demand inducement. Inequity is a huge cost. So there should be, Korea is the case you can learn. You can learn a lot from this. Okay, bad lessons, that when you rely too much on the private provider, even if your funding is public, even if your funding is mainly public, but dealing with this private sector is not an easy game. It's a really big challenge.
This is not to apologize for the Korean government and the Korean systems, but I could say that part of the reason for this, that the huge sort of overdominance of the private sector, healthcare and long-term care services in Korea, has to do with the shortness of the national insurance. For example, Korea's universal health insurance was introduced in 1989, 90 or something like that. Only about 30, 40 years old. Long-term care insurance, 2008. When you compare that to Japan, when Japan introduced national health insurance in 1960s and long-term care insurance in 2000. But prior to that, Japan actually introduced what they call the Gold Plan in 1989 to provide community-based long-term care services at the municipal levels, and have already created the kind of long-term care long-term care and social infrastructures by having community, networks, community clinics, the drop-in centers, long-term care homes and things like that already in place as a part of the public health long-term care services. So when we switched over to long-term care insurance, they already had this physical social infrastructure in place that got taken over by long-term care insurance. And so it was able to sort of utilize its social public system. And then eventually, actually, private sector began to come in, but it's still kind of balancing. And because of that pre-existing template of Gold Plan public long-term care services system, that the Japanese government was really able to sort of put pretty strict regulations on the service quality, the certification of the care workers, all these things. So I think in a way, yeah, Korea is a really good lesson on sort of when you introduce new and completely new system and trying to run with it in a very short time, it's without much in way of the existing social infrastructure. What happens is that you have to rely on private sector to come in, and you lose control kind of over in terms of regulations and coordination, I think.
Yeah, it can be I agree, but also a bit complicated story. I think it's related to history, like in Korea we have a Korean War, and then after that it's basically all infrastructure is gone. Okay, and then we're heavily, of course, Japanese also influenced by Korea, by US, but I think Korea is more influenced by the US. So the creation of a basic socio-economic system is deeply founded by the kind of market-based private system. In that case, you should be very careful. Not the case in Canada because you have a good, as you mentioned, good social kind of public infrastructure. But in many low and middle income countries, in the case of health insurance, when health insurance is introduced, then people have an increased purchasing power. So when the public system is weak, when people do not trust the quality of care by public providers, then insurance comes, then the demand for private providers is increasing. So ironically, as you mentioned, without good infrastructure in the public system, then insurance increased the entry of private providers. So in many low middle income countries of Asia. So I think financing is very important, but financing in health, financing in long-term care is different from pension because pension is a purely financing mechanism. You don't have a service provider. But in health care and long-term care, it's an intermediary. Okay, the true impact of this funding mechanism is going through service delivery system. So that's why we think financing is not, as at the beginning I said, it's not just simply add more money, but it fundamentally, it changes how we raise money and how we allocate, how we discipline, how we monitor, change the service delivery system. That's the difference between health and long-term care from pension. Because this service provider is a very important element.
Okay, I know we were way over the time, but there are two really urgent, important questions. So I am going to ask two people to ask questions, and then maybe we could wrap up. I know we could talk about this all day long.
That's right.
Yeah, go ahead.
So I think it circles back to somewhere that's really important for me, I think, to be thinking about, which is like to the question of service provision and kind of this public-private challenge that we're facing and this push to like expansion. In Canada, again, there's big demand for long-term care coming up. And to me, it centers back to this question of the care workforce, right? Like how we're going to get people to actually engage and be part of the care workforce. And this kind of doubles down on the problem with private and publicly funded systems, because again, private systems are going to be more likely to maybe pay people a little bit more or build systems out to get people services. Whereas there's certain restrictions that come with publicly funded systems. I was wondering, kind of like learning from different comparative cases, we've talked a lot about different countries. In your experience, is there a country we could look to kind of thinking about building a sustainable care workforce? Like, is there a place to lead from example? Is there kind of things that we need to be thinking about as Canada is kind of shifting into understanding what a sustainable care workforce is? Thank you so much.
Yeah, very good question. Unfortunately, I've touched upon some of these workforce issues, but I haven't done very serious research in that issue. But in that case, usually I think that the high-income countries are better positioned to attract many of those foreign workers, in a sense, compared to Korea, for example.
Yeah.
So, but no, that's not. That's beyond my usual answer. That's beyond my expertise. Care work as well. Only, as I said, it's a serious issue, becoming a serious issue in the case of Korea, Japan as well.
Are you sure?
Well, I was just gonna make a point. Professor Kwon, I think for me in Canada, were we to go the extent you, if I'm interpreting you right, you'd like to see in terms of private, we would have to come to Korea and get a heck of a lot of help, because we would need to give our business sector a complete brain transplant. In Canada, in my opinion, our public system is more efficient than the private.
Yeah.
Also, and even in pensions, for example, our public pension providers, like teachers and the healthcare worker called WHO, they're amongst the world's best. You know, World Bank has written them up. They beat the averages. If I could put my money there, I would do it in a heartbeat. Far, far better than a private pension.
You're lucky. But unfortunately, Korean system is basically Korean welfare state. Even the education system. I'm working at the national university, but majority of the universities are private. So as I said, this is a health care education. But in terms of the nature of a Korean welfare state, it's mainly a private system. When the government works, it's not as a service provider, but rather as a funder or regulator. So like health insurance, like funding, but service provider is all private.
Well, I know, I swear we could continue to discuss this all day long, but I think we're way out past the end time. So I would like to, well, one more time, thank you. Professor Soonman for excellent presentation, and thank you, everybody, for your contributions, comments, and questions, and being here. Thank you. And we will contact you again for next seminar. Thank you.
Thank you.